So I'm supposed to cover a very practical question, which is when to stop and when to restart anticoagulation therapy. I may disappoint some of you, but I decided yesterday to reformulate the question in order to reflect better the status where we are. And so I think a more appropriate question at this stage would be, should we start or should we not start anticoagulant therapy in patients with ICH who have AF? So those are the kind of patients that we're talking about, patients with ICH and atrial fibrillation. Should we start or should we not start anticoagulant therapy in these patients? And you will understand the dilemma when you see in front of you the patient, an old woman with history of atrial fibrillation, hypertension, who comes in with an intracerebral bleed, with clear symptoms and with clear findings showing or emphasizing the severity of this intracranial bleed, intracerebral bleed. And you will soon find yourself trapped, if you're in that boat here, trapped in between the six-headed monster on the Scylla side of the Medina Strait between Italy and Sicily. This is a picture or is referring to the myth, the Greek myth that was written about by Homer, the Greek author. You are trapped in between the six-headed monster on the Scylla side and the whirlpool on the other side. You have on one side the threat of ischemic events, and you have on the other side the threat of hemorrhagic events. And so you have a lot of difficult questions to answer. One is, what are really the effects of anticoagulant therapy in this patient relative to no antithrombotic treatment, relative to antiplatelet treatment, or relative to left appendix occlusion? Another question that you might ask is, what is the best agent to choose among the anticoagulants? Would it be a VKA or would it be a NOAC? And what is the best timing of anticoagulant therapy in this patient? Is it after 2 weeks, 3 months, a year? Well, that's another question to ask yourself. And then there's a question, are the effects of anticoagulant therapy dependent on the type of ICH that you have in front of you? And I'm sure most of you will agree that there are things to consider here relating to the type of ICH that the patient has. So what I've done is to try and find some answers in the literature, and I will start by showing 4 observational studies giving us some information about what we can do. And because you will understand there are no randomized controlled trials, so we have to lean on observational data. And some of these studies have been shown earlier in this session. And the first one is a German study by Kuramatsu, published in JAMA 2015, where they took patients with a previous ICH and AF, and they compared patients who were started on oral anticoagulants with those who were not started on it, and looked at ischemic events in the follow-up period and found that patients who were given anticoagulants after ICH, they had fewer ischemic events. There was no difference in hemorrhagic events, and so they found that survival was better in patients who were started on anticoagulants compared to those who were not started on anticoagulants in the follow-up period, a study of 700 patients followed for over 1 year. So that was a German study. Then we have the Danish study, which has been mentioned several times at this meeting, by Nielsen and collaborators, published in Circulation 2015. And they compared not only anticoagulants, but also antiplatelets to patients who were not put on either anticoagulants or antiplatelets a control group and followed them for over a year. And let's first look at the results for the antiplatelets treated patients. You can see here that there was no difference in ischemic events between antiplatelet treated patients and controls, but there were more recurrent ICH in patients given antiplatelets. Patients given anticoagulants, on the other hand, they had fewer ischemic events than control patients, and there were no increase in the risk of recurrent ICH. So looking very promising for anticoagulant drugs in this observational study of 1,700 patients, as you can see down here. Then and they also showed a survival benefit in patients given anticoagulants compared to control patients and also compared to antiplatelet treated patients. And then there's another flag on the top, and this flag is Taiwanese. A big study based on the Taiwanese National Registry with over 12,000 patients. And they also compared anticoagulant treated patients or antiplatelet treated patients with control in the same group of patients. And when looking at ischemic stroke first, they found that there was no difference in risk between antiplatelet treated patients and controls, but there was a significantly lower risk of ischemic events in warfarin treated patients. When they looked at ICH, there was not much difference. I mean, there were more hemorrhagic events in both the antiplatelet treated patients and in the anticoagulant treated patients. And finally, a Swedish study published only a month ago by Johanna Pendlert and collaborators in Umeå in Sweden. They looked not only at whether anticoagulants or antiplatelets were better than control, they also looked at whether timing of treatment made a difference. So what we see here is ischemic events in this cell. We have hemorrhagic events here and the combined endpoint of stroke or vascular death down here. The dotted line is the risk in the control patients over time, which is set to be 1, or what shall I say, that's the reference group. The dotted line, patients in the control group. The gray broad line is patients given antiplatelets, and the darker, thinner line is the risk of is patients giving anticoagulants. So antiplatelets, control patients, and anticoagulant treated patients. And the bolded part of the graphs signify significant differences. So if you look at ischemic events, you see that there was really no significant difference between antiplatelets and controls throughout the duration of observation. But there was a significant difference in terms of ischemic events for patients giving anticoagulants compared to control. For patients given this anticoagulant treatment early, say about 7 to 8 weeks after the ICH. For hemorrhagic events, there was no difference for antiplatelets or for anticoagulants, so it looked safe for both groups. And for stroke or vascular death, there was again a significant difference in favor of anticoagulants, again when given 7 to 8 weeks after the ICH. So this is a very interesting observational study. Then to finalize the question about whether there is evidence for giving anticoagulants after ICH, I also tried to look at evidence or studies comparing left appendix occlusion with anticoagulation alone in this patient group, but I found no data whatsoever. Appendix occlusion is, of course, compared to best medical treatment in observational studies. We've heard about the propensity score matching study, which is becoming published soon. But against anticoagulants alone, there are no observational data that I'm aware of. So 0 patients followed for 0 years. So to conclude this first part of my talk about anticoagulant therapy, I think we can say that observational studies clearly suggest that anticoagulant therapy is safe, as I've shown, and reduces risk of ischemic events. We can also say, based on the Swedish study, that the best agent and best timing is unknown. But the Swedish study indicated that start of anticoagulant treatment, say 7 to 8 weeks after ICH, may be a good time or a better time than earlier or later. And finally, that the effects of anticoagulant therapy compared to appendix occlusion, they are basically still unknown. Then to go to the next question about whether the effects of anticoagulant therapy is dependent on the type of ICH. And I'm sure you're all aware of the fact that patients with a lobar ICH are at higher risk of a new ICH in the follow-up period than patients with a non-lobar ICH. So this is clearly an important distinction between lobar and non-lobar ICH. And here's another observational study from the Netherlands by Nieuwen, Huysen and Klein, unpublished data, where they looked at patients with lobar ICH and compared to patients with non-lobar ICH, and they found not only that the risks were higher in those with lobar ICH, but also that they had a smaller benefit on ischemic events from receiving VKA, and also a much higher risk of a new intracerebral bleed compared to patients with a non-lobar ICH. Complicated picture. I will not use any more time on it. You can have it later if you want. So the second conclusion, just to make it short, is that the effects of anticoagulant therapy in lobar ICH, they seem more unfavorable than in other patients. So the type of ICH clearly plays a role in this setting. Finally, a few words about where we are right now. How do clinicians behave? What are we actually giving to our patients? And this is an overview of practices in different European countries. And most of these studies I have already touched upon. For example, the Swedish study by Pendlert and collaborators showing an 11% proportion of patients starting on anticoagulants within a year after ICH, up to 35% of patients started on anticoagulants in Denmark. So a wide variety of practices around Europe. Lots of uncertainty. And this just reflects that people really feel themselves trapped in between Scylla and Charybdis, between ischemic events and hemorrhagic events. But the very glad message that I have is that there are what's happening here? There are randomized controlled trials being either planned or actually going on. And the first one, Apache AF, is a randomized controlled trial going on in the Netherlands, comparing a NOAC with no anticoagulants in a small trial of 100 patients. That trial is going on. There's a Canadian trial called NASBAF ICH, comparing a NOAC with antiplatelets. There is the SOSTART trial being planned in the UK, comparing anticoagulants versus no anticoagulants. And there's a Norwegian-Swedish trial called STATICH being planned, again comparing anticoagulants versus no anticoagulants. And finally, there's a French trial being planned, the A3-ICH trial, a 3-armed trial comparing anticoagulants with appendix occlusion versus no antithrombotic treatment whatsoever. And the contact person for that trial is Charlotte Cordonnier, who is present at this meeting. So the third conclusion that I've got is that several RCTs are ongoing or planned, which is a very good message to bring. So back to the question, should we start or should we not start anticoagulant therapy? I'm afraid I haven't given you much concrete advice. And perhaps the most important take-home message from my talk, it basically just says that if you have a chance, please randomize patients with ICH and previous ICH and AF into trials of anticoagulants or trials of appendix occlusion. So that was what I had on mind. Thank you very much for your attention.